Hello. Now I'd like to speak to you about drugs of abuse, a very common emergency medicine problem. Cocaine is very commonly used, and it's described as giving euphoria with increased alertness and general sense of well-being to the user. No wonder it's so popular. However, there are a lot of very bad side effects from the use of this drug, and you will see them on the board exam. Most of the side effects center around the intense vasoconstriction and hypertension that the medication causes. Locally, you can see vasoconstriction in the eye from smoking cocaine. It's also known as crack eye, and that can present with corneal ulcerations and sores. You'll also see, even more seriously, life-threatening causes of cocaine use, which are intracerebral hemorrhage, which will present with severe headache, and chest pain associated with cocaine abuse, including myocardial infarction. Rhabdomyolysis and from muscle breakdown has also been commonly reported. So let's take a case. 22-year-old comes in with intense headache, agitation, diaphoresis, tachycardia, chest pain, and PVCs, premature ventricular contractions, on the monitor. What do you want to give? All right? Do you want to give lidocaine for the PVCs? How about giving metoprolol, like a beta blocker, for the hypertension tachycardia? Is that a good answer? Labetalol, nitroprusside, phentolamine, benzodiazepine? Okay, here's the answer. Lidocaine, no. Beta blocker, like metoprolol, absolutely contraindicated, the absolute wrong answer. The reason why is, if you block use the beta blocker, you'll have an unopposed alpha effect. Your blood pressure will be even higher, the patient even sicker. So if you're going to use an agent that has alpha blocking properties, that would be a good answer. You can use phentolamine to control the blood pressure. That's a pure alpha blocker. You could use labetalol, which has some beta and some alpha blocking properties both. Or you could use the standard medicine for blood pressure called nitroprusside. But the answer to this question, the first medicine you'll give is benzodiazepines work to counteract the effects of cocaine toxicity. So in this person with intense agitation and headache and pain, give benzodiazepine first, and then if the blood pressure is still high, I would add either labetalol, phentolamine, or nitroprusside. I would never give metoprolol, a straight beta blocker. Okay, here's another case. You're working at the airport, working at the hospital closest to the airport, and someone comes to you that has been smuggling drugs across the border, and you know that the little condoms full of drugs are radio-opaque, remember? So you take an x-ray and you see these multiple packets in the gut. The patient admits it's cocaine. What do you do? Well, let's see. Do you remember from the general principles of toxicology, I could use the GoLYTELY to flush the packets, to flush the packets out of the body and have them defecate all the drugs. And that would be the safest way to quickly eliminate them. Okay? Under what circumstances would you call a surgeon? If one of these packets broke, the patient would have a severe, overwhelming cocaine toxicity. You would give all the benzodiazepines you can, and you'll use phentolamine to block the severe hypertension. But physical removal of the broken packet before the rest of the drug can leak out of the plastic and into the bloodstream would be a good choice as well. And I wouldn't call a DEA agent. You'll be too busy saving the patient's life. Okay? Treat the patient, do what's best for them. How about opiates? Well, we all know if we give Narcan, the patient will be in acute narcotic withdrawal. They'll feel the pain again, they'll have piloerection, nausea, vomiting, they'll have abdominal cramps. The patients feel like they want to die, they feel like they have a bad case of influenza, but they're not. So If you reverse someone's opiate intoxication with Narcan, they will be wide awake very quickly within seconds of giving the Narcan. Now, what happens if someone who is on heroin or methadone and is overdosed, and you give them Narcan? They wake up, they're fine, but then in about 20 minutes they're going to fall back to sleep. Why? It's because the Narcan has a shorter half-life than the drug that they took, than the heroin or the methadone. So the answer there is to give an additional dose of the Narcan. So alternately, you can start a Narcan drip so they have a continuous supply of Narcan, or you can just give 0.4 milligrams every 15-20 minutes to keep the patient awake. Benzodiazepine overdose. Remember, we're not going to use flumazenil because that can induce seizures. All right? So these patients, it's simply supportive care. Intubation and ventilation is needed, and wait for the patient's own liver to detoxify the drug. That's the answer for benzodiazepine. Okay, let's try this case. What do you do if you find a 30-year-old's found unconscious, they have a pulse, their pupils non-reactive, the respiratory rates, they're not breathing. You do your airway, your breathing, your circulation. They get intubated. You give them Narcan, glucose, thiamine. There's no response. So it's not hypoglycemia. It's not an opiate addiction. You do a head CT. There's no bleed or hemorrhage or mass lesion or signs of herniation. You do an EEG, and it's flatline. Is the patient dead? That's the question. There's a couple more things I'd like to do. One, of course, I want to check their temperature. We'll assume they're not hypothermic. Okay? Temperature's normal. And number two, I want a drug screen, because phenobarb toxicity can essentially mimic someone that's brain dead. So I want to get a drug screen and see if there's barbiturate in their body, in their bloodstream. All right? If there is, remember that this is a case where I'm going to add bicarb to their IV fluid to speed the elimination of the drug. A good way to remember that barbiturates can make you have a flat EEG is the fact that we use barbiturates in severe head trauma. We purposely put patients into barbiturate coma for a couple of days so that there's less metabolic demand from the neurons while the brain is healing after severe head trauma. What do you do for the hallucinogens? People having a bad trip. It could be anything, marijuana, LSD, PCP. The key here is a nice, dark, quiet room, not to be confrontational with the patient, and give them benzodiazepines and let them rest and wait for the hallucinations to resolve. That's the treatment. That's the end of drug abuse.